Good morning. I'm going to talk to you about the usage of e-cigarettes for smoking cessation, which is the first of the novel tobacco products that actually we have some data about it. So we already know that most of the smokers know that they should quit, they want to quit, and a significant percentage have already attempted to quit. But only 3 to 5% manage to quit without medical help. And we already know that in the European countries, and this data come from the Eurobarometer, it's only 5% of Europeans that have attempted to quit using medical support or smoking cessation services. So smoking is no longer attractive, and that is why harm reduction strategy is gaining some space. These cigarettes are already promoted as a safe smoking cessation tool, and the most users of e-cigarettes are current smokers. And one of the main reasons for using them is to reduce or stop traditional smoking. So if we move to some data, and I have chosen data from randomized control studies that are the studies that are more accepted, and there are 4, and in these 4 randomized control studies that are pragmatic, we mainly can see that there was a comparison between the first-line smoking cessation drug that are the nicotine replacement therapy and the electronic cigarettes that had nicotine. The number of participants were between 600 and 6,000. And if we move to the quitting rates that were achieved using e-cigarettes with nicotine, we can see that with the exception of the last trial of Peter Hayek that was published in New England Journal of Medicine, and we're going to talk about this one in details in the next slides, we have seen that the other ones had a very low percentage of success, between 5 to 7%. And what is important to state is to see that, as we can see in the last bar, most of the smokers that actually tried to quit using e-cigarette with nicotine continued to use e-cigarette after 6 months, and we can see that these numbers are from 40 to 80%. There is a meta-analysis that was published 2 years ago from Glance, and this consisted of many trials that have studied the effectiveness of e-cigarette for smoking cessation, and the result was that in all this trial we have seen that there was a 32% lower odds in quitting smoking. These trials also had some problems that some of them are that they have applied different designs, that they had recruited heterogeneous populations, that some of them have provided limited behavioral support, and despite that some of the trials have reported a positive impact on smoking reduction, there is a modest benefit on smoking cessation. We're going to talk in details about them. We should just remember that according to ICD-10 classification of diseases of WHO, nicotine dependence is a disease, and to remember that according to the guidelines, the dual behavioral and pharmacotherapy, pharmaceutical support is the one that can increase smoking cessation rates. The reason that we both need psychological help and pharmaceutical help is that nicotine, as every addictive substance, has 2 arms of dependence. The one is the psychological, as we can see, and the second is the physical dependence, as we can see on the right-hand side. And it is important to remember that the somatic addictiveness that nicotine is causing is really high. So from a scale to 0 to 3, we can see that the physical dependence caused from nicotine is 1.8, and this is much lower than other very known addictive substances such as cocaine, for example. So once a smoker is trying to quit or not smoke for some hours, he is experiencing nicotine withdrawal symptoms. So he is having cravings, headache, he is irritated, his heart rate is decreased, he's starting having a weight gain because he wants to eat more, he's anxious, he's restless, and also he cannot concentrate, he cannot perform, and he's feeling dysphoria or even depression. But if we want to analyze the trials that have compared nicotine replacement therapy with e-cigarettes that are containing nicotine, we should remember the way that nicotine is delivered when we are smoking or we are using electronic or heated cigarettes. And this route is the inhalation route that we can see on the left-hand side. So when we are inhaling nicotine, nicotine is going to our arterial bloodstream and then to the left side of the heart, and it reaches the brain in few seconds, less than 10 seconds. This is not the case when nicotine is delivered through, for example, nicotine replacement therapy, either patches or the other forms of NRTs. Then nicotine is entering the venous stream, then it goes to the right side of the heart, and after it goes to the left side of the heart and it reaches the brain. And this route, as you can understand, needs much more time. But it's not only time that is the difference between nicotine when nicotine is delivered through e-cigarettes or through nicotine replacement therapy. It's also the level of the concentration of nicotine that are achieved in the two cases. So we can see on the left-hand side that when we are smoking, the blood concentrations of nicotine are rising quickly during a smoke, and they peak at the completion of smoking, and these levels after some hours, 1 or 2 hours, are decreasing, and then the smoker, if the smoker does not smoke again, he's starting feeling the withdrawal symptoms. And if we want to see a comparison between the levels of nicotine that are achieved while we are using cigarettes or e-cigarettes, we can see on the right-hand side some of the nicotine levels that are achieved with cigarette and some of the older cigarette that have been used in Peter Hayek's trial, where is this scheme coming from. And on the left-hand side, we can see the levels of nicotine that are achieved when we are using either patches or sprays of nicotine or gums or inhaler, and we can see on the left-hand side that these levels are achieved after more than 10 to 20 minutes, and also that they cannot reach the high concentrations that are achieved when we inhale nicotine. So we're going to spend the rest of our talk trying to analyze Peter Hayek's trial, which is the trial that actually showed that the e-cigarettes could achieve 18% of quitting rates while they're used for smoking cessation. And indeed, in this trial, there were two arms. In the first arm, there was smokers that used e-cigarette with nicotine. In the second arm, there were smokers that used nicotine replacement therapy. One of these forms, although they were advised to use the combination, it was not the case. That's what we're going to see. And the results that have as a result to give a very big big noise was that the abstinence that have been achieved using e-cigarettes with nicotine was 18%, and in contrast, the abstinence that was achieved using NRTs was 10%. But let's see if these results have also some points that should be addressed. As we have already said, in all of these trials, in the end of the trials, most of the smokers that tried to quit had continued to smoke, and this is the case also in this trial, where 80% continued to use cigarettes in the end of the trial after 1 year, which means that only 3.6% of the smokers have quitted from all tobacco products. This is not the case with the NRTs, where actually almost all of the smokers who tried to quit and has succeeded to quit did not continue to use NRTs in the end of the trial. And some other points that are important are the following ones. The very important point that should be addressed is the difference in the adherence in the two arms. So the adherence to treatment in the e-cigarette arm was 41%, and this was not the case in the NRT's arms, where the adherence was 7%. We can understand that since the addiction of nicotine and also the levels of nicotine is almost the same while using e-cigarettes, this is easier to do. Sorry, I thought that the moving has stopped. But what is surprising for us that we are dealing with smoking cessation in our everyday life is that we know that the effectiveness of nicotine replacement therapy when they are used in smoking cessation treatment and smoking cessation outpatient clinics, or they are not used over the counter, is higher than the one that is seen in this trial. So in Peter Hayek's trials, we have seen that the abstinence was 10%. We know that the effectiveness of NRTs is from 20 to 36%. And in most of the trials, the 10% of effectiveness is even seen in the placebo arm. And this is something that is very important to state, because we know that in order that nicotine replacement therapy is effective, they should be used for 3 months. They should be used in all the formulation in the way that is prescribed, and that the combination is leading to the highest quit smoking cessation rates. That usually what is happening in real life is that NRTs are underdosed, or they are using over the counter, and it really makes an impression for us that we have seen abstinence rates of 10% in usual practice in England, and this could reflect the NHS decrease in funding or the hardening hypothesis. Lastly, we have also some other points to address in this trial, and this is that in the e-cigarette arm, a free choice of e-liquid was permitted, and we already know that flavored e-liquids have been proved to be more attractive to users. And from the other hand, the combination of short and long-acting NRTs that was advised was not used from all participants. And most importantly, doctors that are using smoking cessation and are smoking cessation experts have been trained, and there are guidelines for smoking cessation. For example, I'm going to show you something that has not been addressed. We already know that if a smoker has already tried to smoke and has used pharmaceutical therapy in his trial. Then when we are going to trying to help him in a second attempt to quit, we should know and follow some guidelines. For example, we should know which drug he has used in the past, if he has experienced any side effects of the drug, if he has any treatment preferences. And to give you an example, if, for example, a smoker has used NRTs in the past and it finds it was used in an adequate dose and it was unhelpful for him, then in the second time he should use a different drug, not NRTs. And there are specific guidelines that should be used in order that we can use pharmaceutical treatment in a second time. And in Peter Hayek's trial, all the smokers have already tried to quit in the past using NRTs, and these have been unhelpful. So we believe that in this second effort, all these matters, all these determinants should have been addressed. And we already know that this trial has been done in the UK environment, where more than 900,000 people have already used e-cigarettes. And we know that in England, over than half of the quit attempts are made with the help of e-cigarette. And this is demonstrating also the willingness of smokers to use a product, e-cigarettes as cessation aids in large numbers in countries that they are promoting their use, and this could be in the detriment of NRTs. And we believe that since in this trial, the smokers had already a previous negative experience, and they were in an environment that already is promoting e-cigarettes. This could result in the characterization of NRTs as an inferior option from the participants in the NRTs group, and this participant could have put less effort in their quit attempts than those that the e-cigarette group. So these points should have been addressed in this or next trial in order to have some results that could be more convincing. And until then, we know that only NRTs have been proved to be evidence-based for tobacco harm reduction, and that these are extremely safe and less addictive than the e-cigarettes. And to see what is happening in real life, I have chosen this graph that actually is a graph that is showing the reduction in smoking rates in 3 countries that have already an excellent tobacco control. These countries are England, the United States, and Australia. But these countries also have a difference in the percentage of people that are using e-cigarettes. So in England, we have a percentage of 6%, and this percentage is far much lower in the United States, where it's less than 3%, and in Australia, where it's only 1%. And in these countries, if we see from the last years, we can see that the reduction of the smoking rates is almost the same, although the usage of e-cigarette is much higher in England, for example. And that is why we believe, and this is something also that was stated at the BBC from Robert West, that if they were the game changer, they would have a more massive effect, and they would we would have seen a bigger effect, a bigger decline in England, for example, that where it's a country that e-cigarettes are using in such a high percentage. The same is also stated in this publication that was done 2 years ago, where we can see that from between 2006 and 2016, although the usage of e-cigarette is increased in England, the cigarette consumption is almost the same, so the effect was very small at the population level. And this is done While the pharmaceutical therapy is decreased. So in England, we can see that between these years, the e-cigarette usage is increased from 2012 to 17. And this is in contrast with the usage of smoking cessation treatment and smoking cessation services. So we also are seeing the authors in many publications, because many of you could state that there are also other publications. And what Charlotta Pissinger has shown 1 year ago, or they found with her team, is that actually the publications that have been done from authors that had conflict of interest with e-cigarettes had, as a result, showing less harm than the ones that have been done from authors that did not have any relationship with the tobacco industry or with e-cigarettes, but they're autonomous. So lastly, what we would like to make as smoking cessation experts is just a call to healthcare professionals to use smoking cessation and to implement them in their everyday clinical practice, since there is insufficient evidence that e-cigarettes could be effective for smoking cessation, and in pragmatic trials their quitting rates are very low. We also are seeing that e-cigarettes are displacing evidence-based smoking cessation therapy in real world, and that most e-cigarette users are either dual users or do not use e-cigarette as a smoking cessation tool but as a supplement. And we know that clinicians have many problems, as George has already stated in his talk previously. They may lack of experience, they may lack of financial resource or time, and maybe for them e-cigarettes could be used as shortcuts. And we can see in this publication that healthcare professionals are not engaged in smoking cessation because they are frustrated, because they are not trained, they do not have experience in smoking cessation technique, and they have negative attitudes towards patients that smoke, and this has a result the lack of their engagement in smoking cessation treatment. But since we have seen many acute hazards that have been results for e-cigarettes, and many public health concerns, such as renormalizing smoker, such as undetermining smokers' wish to quit and ex-smokers' wish to stay smoke-free, such as addiction that is maintained with the usage of e-cigarette, that they can be either dual users or they're switching to e-cigarette. There is a big interest and also fear about initiating smoking in minors and the long-term effects that are still unknown. And since their evidence compared to licensed smoking cessation medication is weaker, we just urge, in this context of smoking cessation, to use optimal behavioral and pharmaceutical treatments. They should promote these two that have been proved to be evidence-based before they recurs to the use of e-cigarettes. And I want to acknowledge my team that is fighting all these years and helping in smoking cessation in Greece, and thank you for your attention.